have the handouts, if not, it's being passed around, I think. So the topic I'm going to cover this morning is pediatric sepsis. Can you all hear me okay? So here's some goals and objectives for the class today. The goal is to educate you guys in the assessment and early recognition of severe pediatric sepsis. And like I said, it's usually seen in the ICU setting, but you will be exposed to it down the line. The objectives: to recognize sepsis and severe sepsis, to recognize the signs and symptoms of sepsis and severe sepsis, including vital signs, physical assessment, and lab results, and to recognize respiratory failure, inadequate tissue perfusion, and organ dysfunction in the sepsis patient. This is just two pictures of patients in the ICU setting. This is usually what you'll see. And sepsis is a big deal. It estimated over $200 billion in the United States of healthcare bills, and over 4,000 children die in the United States each year with severe sepsis. And here's just some evidence-based practice. They've been doing a lot of research on sepsis lately, just to get everyone informed. There's new sepsis initiatives out there to get mostly all hospitals in the United States on the same page with orders and just how the treatment is. At face value, more children die from sepsis every year in the United States than from cancer. There's a growing need for educating the public on the dangers of sepsis, particularly in children. According to the World Health Organization, sepsis accounts for 60 to 80% of lives lost per year in children. That's a lot. That's more than even cancer, and you wouldn't think so. There's so much research out there for cancer right now, but not for sepsis. So we're really trying to get that going. And basically what they're doing now is a triage protocol, which you can see in the binder I'm passing around is the ED triage sheet, and that's just for early screening. And these are just basic definitions. Sepsis, it's an inflammatory response to a suspected or documented infection in the blood that's spread throughout the body. And then severe sepsis is when there's organ dysfunction. There's hypoperfusion, which is inadequate tissue perfusion, and then low blood pressure. Low blood pressure is an initial sign, but you will see that after you see some organ failure and vital sign deterioration. And SIRS is basically the umbrella term. It stands for Systemic Inflammatory Response Syndrome. Basically, sepsis and severe sepsis both come under this term, how it's documented. And these are some high-risk groups, which I'm sure many of you have seen already in clinical. Infants, the low birth weight infants, the premature babies that we see, like the X37 weekers that they call them, immunocompromised, so many patients that are there for chemotherapy, neuromuscular disease, congenital heart disease, and chronic lung disease. So now, what is sepsis caused by? It's a result of an infection, microorganisms, bacteria, viruses, fungi, and parasites. It just gets into the blood and spreads very quickly. Diagnosing. Since it is life-threatening, it needs immediate attention. They like to see diagnosis and treatment starting within 1 hour of coming into the ED. So any pediatric patient screened in triage that meets the criteria for sepsis must be immediately evaluated by a licensed healthcare provider, which is one of the pediatric attendings, usually in the ER, and the residents. And then any patient that they even suspect is septic, they put into the protocol. And that's why many of you have probably seen on the floors the rule-out sepsis babies. They come in and they basically do the whole sepsis workup and then it's ruled out. It's better to do that than to wait and let something slide by. Okay. And this is what we do usually in assessment. They do blood tests, CBC, ASTRA, ABG, VBG, a lumbar puncture, which is a spinal tap. Some of you, I think, have even seen in clinical spinal taps. Blood cultures, urine cultures, physical assessment, and then vital sign assessment.
Heather, what's ASTRA?
And ASTRA is a CBC, a BMP, electrolytes.
Okay.
Some of them, BMP, CMP. I guess the hospitals will call
Everybody
them
okay
something
with that?
different.
Yeah, no.
Basic metabolic.
It's a basic metabolic panel. It just tests all the electrolytes, the sodium, potassium. Now this comes with the diagnosing criteria. Usually it's always a fever or a low temperature. So hyperthermia is considered anything 100.4 or higher, which is 38 degrees Celsius. And then hypothermia, which is a low grade temperature, is 96.8 Fahrenheit and 36 Celsius. And then abnormal vital signs. So it's the two criteria together. Diagnose sepsis. It wouldn't be one, even if the baby has a temperature and everything else is normal, you wouldn't necessarily think sepsis. And just a low blood pressure without a fever, you wouldn't say sepsis either. They would both be together. And this is just a chart of the vital signs. This is what I gave you guys in the beginning when we did the orientation for clinical day. Just so you know the ranges if something is abnormal. It's basically the same as on the little card I gave you. And you just take in mind the age. We know now that the babies, their heart rates are higher, 180s. 160s is normal. But if it's a 12-year-old with a 160 heart rate, then we know that's too high. And the same for the respiratory rate. Any questions with the vital sign ranges? Okay, so now when a patient comes in for sepsis, this is basically when we're going to consider sepsis. Right, any baby that's under 1 year of age, particularly coming in with a fever or a low grade temperature, they'll generally always do a rule out sepsis workout on them.
1
You
year
know-
or 1 month?
What was that?
1 year or 1 month?
1 month. The whole first year, we would be concerned, but particularly a 1 month baby, because think about their immunity, what they're exposed to, they're so little. I mean, they do still usually have the mother's immunity for the first few weeks, but still, if a baby that little is coming in with a fever, we're concerned. Immunocompromised, an oncology or a transplant patient. And then any patient with an indwelling device, like a PICC line, a Metaport, because that's a central line going right into the bloodstream. So any fevers with them, we're very concerned. And same with Foley catheters, that's another indwelling device. And then altered mental status. Sometimes that's the first indicator. There's been patients that have come in with a fever, their blood pressure's a little bit low, and then as soon as you notice like mental status deterioration, then you know there's a change. So usually with kids, we depend on the parents for their baseline, because every child's at a different developmental level. You might not know them just when the first time you meet them, so this is when the parents come into play. And then also poor tissue perfusion, oxygen saturation less than 92%, and then a rash, a reddened raised rash, TPI, referra. Okay. And severe sepsis. This is when there's organ dysfunction. 1 major organ or 2 minor organs.
What makes it a minor?
I'm going to get into that
Okay.
next slide. And you would need sepsis with the organ dysfunction. So you would have a fever, maybe tachycardia, and then the organ dysfunction. So now it's the 3 all come into play together. Okay, so then I'm going to get into the organ dysfunctions. The major organs, cardiovascular and respiratory. The cardiovascular organ dysfunction, you're going to see hypertension, the need for vasopressors, which is going to raise the blood pressure. And then any 2 of the following: metabolic acidosis, serum lactate greater than 2. Usually you want the serum lactate to be less than 2. Urine output less than 0.5 mLs per kilogram per hour. The capillary refill greater than 3 seconds. This just basically shows poor tissue perfusion. Okay, and then respiratory-wise, oxygen saturation is less than 92%. Struggling to breathe, labored breathing, things like that. You know when the child's in respiratory distress. We covered respiratory already. Okay. And then if you need a ventilation, the child's desaturating, having labored respirations. you might need a ventilator. One of you, I think it was Melvin, we had the patient when we responded to the rapid response in clinical for respiratory deterioration. That was the day I was working with Jen. Okay, now the minor organs. Neurologic, acute change in mental status, Glasgow Coma scale less than 11. Hematologic, platelet counts greater than 80,000. Elevated clotting factors, which is the PT, PTT, INR. Renal is the creatinine greater than 2 times the normal. Normal range is usually 0.6 to 1.2. And then hepatic would be elevated LFTs, liver function tests. Any questions about the organs?
So you said like the mental status probably is like the first thing you actually notice?
Well, it could be the first thing you notice, because if you have a patient like on the floor setting, you know, you're doing their vital signs every 4 hours and they didn't have a temperature the last time you checked, and because you can go septic pretty quickly. But then you notice that the child isn't acting right or talking, saying stuff that just doesn't make sense, that's an indicator. But it wouldn't necessarily be the first thing you saw,
Just like
but it could be something the parents recognize at home, because their kid could just be normal and then just start acting weird, and their vital signs could be out of range because they aren't checked at home. And these are just some lab results. I don't expect you guys to know all of them. It's just to give you an idea of what to look for in the clinical setting. One thing that is important is the lactate level, and I do have that on the box on the side. That's basically a marker now that they're using to indicate sepsis. It's a useful marker for hypoperfusion, and and they also serve as an endpoint for resuscitation in patients. So once that starts to normalize the lactate level, you realize the patient's being treated well. And we get the lactate level when we do the blood gases. I can go through them. You have leukocytosis, which is high white count, neutropenia, thrombocytopenia, coagulation. The total bilirubin is elevated LFTs. Creatinine is 2 times the normal value. Serum lactate, like I said, is greater than 2. Metabolic acidosis, and then hypoxemia. Arterial hypoxemia is seen on arterial blood gas.
You said lactate levels are, what did you say were kind of where?
They're done on the blood gases.
Okay.
You guys okay with this? And this is just ABG interpretation. This is just a review also. Okay. You know the normal values on the side, the pH 7.35 to 7.45, PaCO2 36 to 44, and the bicarb HCO3 is 22 to 26. So in sepsis, we're going to see acidosis, either metabolic or respiratory. So you know the acidosis is the lower pH. And then with metabolic, you're going to see the bicarb less than 22, usually caused by inadequate tissue perfusion. And then respiratory acidosis is respiratory distress, basically ARDS. And that's when the CO2 is greater than 44. Now management. This is the big thing. Basically, you want to treat within 1 hour. So that's why when I passed around that binder, we do have that triage protocol, so we can make sure that everyone's on the same page in treatment. Early goal-directed therapy provides significant benefits with respect to outcome in patients with severe sepsis and septic shock. So the 2 things we want to do is fluid resuscitation and antibiotics. Now, you know, we're not doing the orders, the doctors are, but just be aware of this. When the patient comes in, you're going to be wanting to give fluid boluses. And it's rapid. So it's 60 to 80 milliliters per kilogram of an isotonic solution, and you give it in 20 ml per kilogram increments. So it's generally 3 separate boluses over the hour. And then antibiotics, which are also on those doctor order sheets. They have specific antibiotics for the age ranges. And then immunocompromised patients have another set of antibiotics that they use. It's usually vancomycin, gentamicin, and we use meropenem for the immunocompromised patients.
not within the first hour, say, okay, like, it would happen at home, and they bring in,
Right.
could you still first do these?
Well, it's the first hour of like getting into the ER,
Oh, okay.
but, yeah, because you don't know how long patients are at home when they're sick. And they can go septic in the room in the hospital too, just as easily.
Right.
But you can, patients are still treated after the 1 hour, but now with all the studies and the research going on, they wanna really get it within the 1 hour time frame because it's a much better patient outcome. They just wanna make like the healthcare providers more aware.
Mhm.
Now nursing care, this is what we're gonna be doing, monitoring vital signs, obviously. If something seems abnormal, we're gonna recheck it, we're gonna let the doctors know, we're gonna be on top of it. Because something as little as a temperature can escalate and get higher, so that's why when we take our vital signs, it's really important that we let someone know. And then monitoring response to the fluid bolus. So when you're giving those fluid boluses, the 3 boluses, you wanna make sure that the patients are, are peeing. So a lot of the times there'll be a Foley put in, or otherwise you're having them measure their urine in a urinal, or we weigh the diapers like we do in clinical. And then ensure the antibiotics are administered. Because the doctor will order them, but then it's up to us to, administer them, follow up with pharmacy, make sure we have it, it's on time. And then emotional support to the families, which you've seen with the kids. Parents, if they see their kid deteriorating, it's hard. So as much as we're focused on the patient at the time, you also have to take into consideration the family. And that's getting a lot easier for you guys. I know in the beginning in clinical you were so nervous going into the rooms, but it gets easier. Any questions about that? So now this is the end point. When the patient's treated, you're going to have normalization of heart rate, capillary refill less than 2 seconds, normal pulses with no differential between central and peripheral pulses, warm extremities, which indicates good perfusion, urine output less than 1 milliliter, urine output should be more than 1 milliliter per kilogram per hour, and then normal mental status. Just change that so you guys know it's more, you don't want less than 1 milliliter. It's usually actually 0.5 to 1 milliliter.
So 0.5 was the dad.
Yeah,
And
less
then 1
than
or more is
0.5. So they want 1 and greater,
Okay.
but anything less than 0.5 is a big concern. And then, like 0.5 is borderline.
Mhm.
Okay, this is just some endpoints in practice that we've seen. It's suggested that children with septic shock receive treatment according to the American College of Critical Care Medicine guidelines, including goal-directed therapy, which provides a systematic approach to resuscitation of septic shock, targeted to specific improvements in physiological indicators of perfusion and vital organ function. Rapid infusion of isotonic solution, which is normal saline, and early administration of empiric broad-spectrum antimicrobial therapy are essential actions. Improved prevention and treatment of sepsis could have a substantial effect on survival and quality of life of all children, both those who are otherwise healthy and those who are chronically ill. Now, nurses, this is what we do. Nurses in a variety of settings, from long-term care facilities to open-heart cardiac care units, will care for patients with severe sepsis. As nurses, we are in a unique position to identify patients at the earliest signs of sepsis and prevent the spread of severe infection. Early recognition allows for appropriate treatment to begin sooner, decreasing the likelihood of septic shock and the associated cascade of life-threatening organ failure. So basically, it's just prompt. You just want to treat right away. And now this is a case study, because I know most of you have not seen a patient who is septic, besides the rule out septic leaves that we had on the floor. This is the patient that you could see. It's a 15-year-old male with no past medical history, no significant family history. He presents to the pediatric ED with lethargy, generalized pain, weakness, decreased urine output, and inability to ambulate for 1 day. And he had, you wouldn't think this was a big deal, but 1 week of increasing left shoulder pain with redness and minor swelling due to injury in the baseball game. What do you guys think might be wrong? Any ideas?
Poor tissue perfusion.
Yes. Good. Anything
like decreased urine output comes out to me first. It's the first thing I thought.
Right,
And lethargy.
right. So, maybe he has an infection, maybe like a virus, you're not really sure what's going on. And then the inability to ambulate, he really only hurt his shoulder, so why can't he ambulate? What's going on? So now the family obviously brought him into the ER. On the physical exam, he was pale and sweating, lethargic, decreased breath sounds at the bases bilaterally, diffuse abdominal tenderness, and decreased bowel sounds, left shoulder pain. This kind of seems like there's more involvement than just the shoulder. What do you guys think? And then look at the vital signs. How does that seem for you? Does anything seem
Heart rate's
abnormal?
high.
Yeah.
Right.
Temperature is low.
So that would be like indicator that something's not going on. Right. And then these are labs, you would say. But again, I don't expect you to know all these levels, but what stands out is the lactate, 4.1. That's pretty high. pH 7.24, so what is it?
Acidosis.
Acidosis.
Where's the lactate?
It's
Oh, no, 4.1.
bicarb 23.1, that's basically normal. PCO2 is low and the PO2 is high. I'm sorry, opposite. PCO2 is high and the PO2 is low. So you know there's respiratory involvement. And these are some of the other labs that you would see. The electrolytes towards the bottom, that's what the Astra, that's what you would see. I'm sure you've seen these in clinical.
Look at the platelets.
And the platelets are very low. White count's low. The H&H is normal. Okay. So just in, in clinical and upcoming, you can start to take more look at labs and kind of see what's going on and look at the big picture. That's basically all. Just I have that binder going around, and you guys, like, you can look after class, or don't look while we're kind of up here because I want you to pay attention. But you can see the order sheets in there. Just some of the policies and procedures for sepsis. And there's a good article on infant coming in with a fever on the Daily News. You can even look that up on your own time. It's an interesting article. Does anyone have any questions?
So in the case study, he hurt his arm in baseball, which then turned into an infection and then turned to
Yeah.
sepsis? Okay.
It did. So
It's like any injury can become
it can,
septic.
just because there was the inflammation. And,
Okay.
he might have had like a little opening
Mhm.
there. And it just, got, even like a cellulitis, you can go septic from that. So the area was red, it was swollen, and the infection just spread.
Is there always like a cause for sepsis? Like,
There really isn't
You
always
could
a
just-
cause, no. That's the thing, that's why the prompt treatment
Mhm.
is, they're trying to do a lot of studies now and research, try to see what causes it.
Mhm.
Why
It's
certain
just-
patients go septic and
It
others
could just be anything.
It could be. Have any of you had other patients that have been septic that you've seen?
At work, I've bumped them back and forth for roulette sepsis.
You'll probably see it in upcoming clinicals, and we should be more aware. That's it? Yes, you have. Okay.
Yeah.
What was your patient like?
She had a gastric band. Then she had a baby, and I think there's a certain time period that is supposed to pass before you should have a baby. So she was,
Right.
The pregnancy was making her eat, so I don't know, something went wrong with the band. And then on postpartum, she started hemorrhaging, or what they thought was hemorrhaging. Then, after they examined her, they realized that she was not, her uterus was fine. Then they called a cardiologist and they did an x-ray upstairs and they found out that she had eaten so much that food had gotten out of the stomach and was in the intestine, where you could see pieces of chicken and stuff.
Wow.
So by the time they were able to figure what was wrong, because in the morning, I remember downstairs, we had gone into the room and the nurse was like, do you smell vomit? And she was like, no, I didn't throw up, but she was fine. So before like 6 o'clock, she was in the ICU septic. I don't even think, they said they don't think she was gonna survive because all that stuff was inside and
Right.
she had been eating like that for,
So it was pretty quick that it happened?
it was pretty quick, pretty quick. It was terrible.
Yeah,
And compounded because she just had a baby.
and she just had the baby, wow.
Yeah.
Yeah, that is a lot. So, happens. Okay, so I'm basically done, we're gonna move on.